All right, good afternoon, everybody. Thanks for joining us today. Today we have another great speaker in our Advanced Heart Failure and Transplant Cardiology series. I'm happy to introduce Dr. Nick Hendren. Dr. Hendren's joining us from UT Southwestern. He went to medical school at the University of Wisconsin, but has completed all of his graduate medical education at UT Southwestern, internal medicine residency, general cardiology fellowship, and Advanced Heart Failure and Transplant Cardiology Fellowship, and after that time joined the faculty at UT Southwestern. He's going to give us a great talk today about endomyocardial biopsy, and very happy to have him. So Dr. Hendren, thanks so much for taking the time, and please take it away.
No problem. Thanks so much for the invitation. And hopefully everyone is staying warm across the country. Certainly it's a little colder than usual in Dallas. So, really my charge today is going to be to talk about endomyocardial biopsy and the evaluation of myocarditis and then infiltrative cardiomyopathies. And, certainly I think as we think about the role and guideline recommendations for that, you have to understand a little bit of the context of the disease and the clinical presentation, because as we all know, yes, it's nice when you're looking for a given clinical entity like AL amyloidosis or TTR amyloidosis, but oftentimes patients come in with a clinical presentation and the etiology of that presentation is not so clear, at least in that moment. So just reviewing back, looking broadly at myocarditis, there's a number of etiologies of myocarditis you can see here, and not that we'll touch on all of them, but did want to highlight a few in blue there that really are kind of underappreciated, I think, or relevant for the advanced heart failure and general cardiology fellows. And we'll touch on a couple different themes for individual kind of patterns that might indicate when biopsy might be indicated for those patients. And so, I think we all are familiar with patient presentations like this, where you have a young man coming with no prior medical history, several hours of chest pain, chest pressure, cold preceding his symptoms a few weeks ago, no real remarkable social history, no medications, no supplements, appears well on exam, no clinical heart failure. And on your bedside POCUS, fortunately has preserved ejection fraction with normal chamber size and wall motion. But the reason the ER is calling you, or the hospital is calling you, is that the troponin is markedly abnormal. So we use a high sensitivity troponin here. So in nanograms per liter, 1400, 1500, and 1600 respectively is highly abnormal and certainly going to give quite a bit of attention, to that patient for the ER physician. Now, as that patient is admitted to the hospital, as a consulting provider, of course, you diligently want to exclude obstructive coronary disease, and given the pretest probability, he has non-obstructive CAD. And so the clinical suspicion now, of course, is a viral associated or autoimmune kind of myocarditis. And so what does that look like for these patients when they come in? Now, if you look at probably one of the largest registries looking back at acute presentations of myocarditis, the Lombardi study out of Italy really encompasses probably the largest cohort, around 400, 450 patients or so. And at least for their observation, they divided patients into complicated and uncomplicated presentations, which ultimately tends to be useful, as I'll touch on in the next slide here. But, patients present with the typical prodrome of symptoms that we're all really accustomed to from that perspective. And so, things like chest pain, fever, a viral prodrome are very common in most patients. And importantly, many patients have markedly abnormal EKGs and CRPs, although it's not necessarily all that helpful. Again, if it's negative, it doesn't rule out myocarditis, but sometimes can be helpful to, again, provide concordant information about the diagnosis. Now, again, I touched on the idea of trying to stratify by presenting disease state. And so they define complicated as someone presenting with cardiogenic shock, VTVF, or a reduced ejection fraction, as compared to an uncomplicated presentation, which is really a predominant presentation for most patients with myocarditis. And that tracks very closely with short and subacute prognoses for these patients, which is really important as we start to think about risk stratifying these patients for who might need biopsy or benefit from biopsy, to look for causes that could be reversible, such as giant cell or sarcoidosis. And those patients that have a low risk presentation, which you can very safely defer biopsy and therefore just watch them clinically over time. Now, this is the data from that observational study, and they have essentially the overall prevalence of cardiac death and transplant over time. This is index hospitalization. Again, you can see this is the overall rate here. And then if you stratify by complicated versus uncomplicated, the patients with uncomplicated presentations, again, normal EF, no VT, no VF, and no cardiogenic shock, have an excellent long-term 5-year survival. And so really those highlight kind of a lower risk patient population, as opposed to those other patients with higher risk factors in which you might be more inclined to proceed biopsy. Basic workup, I'll just touch on briefly. I think all of us know how to do that. We're going to do some basic lab workup, clinical history, EKG, echo, and then look at, for most patients, their coronary anatomy. And then we'll get to, obviously, to endomyocardial biopsy. I do want to highlight that CRP, ESR is probably not all that useful for these patients. Again, elevated doesn't really help you that much. If it's negative, it doesn't really help you that much. And then specific antiviral studies probably don't lead all that much. Now, the contemporary diagnosis is really an inflammatory disease, the myocardium, that can be provoked by an infectious cause or a different cause that leads to an immune-mediated activation and inflammation syndrome. And there's really two pathways to a contemporary diagnosis. There's the original clinical syndrome, right? Someone's presenting with chest pain, and then you go on to biopsy them, and there's pathology-based criteria. And then there's a more contemporary clinical syndrome plus an imaging and a biomarker-based, typically an abnormal troponin, or some people will use CKMB, plus typically an MRI, as we'll touch on here. Now, the original pathologic criteria were created in the 1980s when MRI was not widely available, and certainly we did not have the contemporary knowledge that we do about myocarditis. And the aim was really to create a uniform pathologic diagnosis based upon this biopsy. And what they really brought everyone together on was looking for an inflammatory infiltrate that was associated without the evidence of an ischemic event. So it's not changes that were seen by a myocardial infarction, but really related to almost a native rejection-like process. You can see all the lymphocytic immune cells infiltrating and causing myocyte damage here. Now, the risk of biopsy is not benign, so we know that it does carry a risk of severe complications, including perforation or tamponade, somewhere around 0.1 to 0.5%. For centers that have heart transplant programs that are routinely biopsying, it probably is true that their overall severe complication rate is lower. But again, the risk of biopsy complications in a native heart as opposed to a transplanted heart certainly is at least 1 to 2-fold higher than those hearts that have been transplanted. In general, if you're going to go for a biopsy, you want to have at least 5 biopsy specimens. This improves your diagnostic yield to around 60, about 2/3. If you have less biopsies in the order of 3 or 4, you lose about 10 to 15% for each less biopsy. And then some labs will do additional staining to try and provide improved sensitivity or specificity, although again, the data supporting that is a little bit unclear. However, there's quite a bit of sampling error, variability, different labs were calling different things, and certainly biopsy and pathology was not widely available. And so that led to the need to really move forward and create an MRI or imaging-based diagnosis. Now, as many of you are aware, we have the cardiac MRI protocols related for myocarditis, and I'm not going to spend a ton of time on that, just highlighting now that the most updated version of that, the 2018 Lake-Louise criteria, includes a requirement for both a T1-based imaging abnormality and a T2-based imaging abnormality. And so now, as we look for a contemporary diagnosis, you kind of, again, have 2 pathways. You have a clinical syndrome plus either a myocardial biopsy for these patients that meet the contemporary histologic diagnosis, or more often patients are having this syndrome and abnormal troponin and then have a cardiac MRI that ultimately leads to the diagnosis of myocarditis. Now, again, myocarditis diagnosis in and of itself doesn't tell you what the cause is. That's left for you to figure it out. It's like calling a patient a non-ischemic cardiomyopathy. You've ruled out certain things and kind of put it in a box, so to speak, but you still have to assess whether or not there are specific conditions such as lupus-related myocarditis, giant cell-related myocarditis, or other things that might be relevant. And again, we know most patients do well, but some patients do need further assessment. I'm just going to touch in a little bit more detail about infection-associated, viral-associated myocarditis, and this is the most common etiology that's going to be leading to these presentations, and certainly it's going to be something that will be on your boards. So we know that most viral-associated myocarditis really are not related to the virus itself. And so the virus, shows up, you get a cold that leads to immune-mediated activation. That level of cytokine derangement may lead to a small amount of myocardial injury that then exposes cardiac antigens that can be picked up by your immune cells. And then for reasons that we don't well understand, sometimes yourself misappropriates these proteins as the virus or some sort of foreign entity and leads to kind of a chronic myocarditis inflammation. It is true that sometimes some of these proteins that are released may mimic some of the viral proteins. We call that molecular mimicry. And that may be one pathway in which these epitopes are a little bit more shared and lead to this long-term propagation. But it's really not all that clear. But nonetheless, this viral associated phenomenon does explain why patients oftentimes have a preceding viral prodrome anywhere from 1 to 12 weeks in advance. They're typically viral negative for PCRs. And so it really, again, is that immune mediated response rather than the virus itself. And so again, looking for specific PCRs may not be the most helpful for those patients. Again, just to highlight this in a different kind of way, there's that initial viral exposure. Patients get that triggering signal. They then have come in with their acute myocarditis here, oftentimes negative for virals. Viruses are very low level titers. They have their chest pain, their troponin elevations, their abnormalities. And then most patients turn off their immune system, meaning they go quiescent, that inflammation goes away, those chest pain symptoms go away. Unfortunately, somewhere between 5 to probably 10% of patients have this chronic prolonged immunologic activation that can lead to long-term inflammation in the heart and lead to a chronic inflammatory cardiomyopathy. In the Venn diagram of a viral associated chronic inflammatory cardiomyopathy, sarcoidosis, giant cell, there's a lot of overlap and kind of immunologic milieu, if you will. And so separating those out sometimes can get challenging, even on biopsies for patients. So what is a useful way to kind of strategize and think about how to stratify these patients and who might benefit from biopsy? So I think what has been helpful for me is to essentially break them down into an acute uncomplicated presentation. Again, those patients that are low risk, an acute complicated presentation, patients that are higher risk, although many will continue to do well. And those patients with kind of prolonged ongoing myocardial activation, inflammation, so-called inflammatory cardiomyopathies. For those uncomplicated patients, you get them feeling better, you get them out of the hospital. You want to repeat that MRI in 3 to 6 months to ensure that there's resolution of that active T1, T2 abnormalities. And if there's still active inflammation on that repeat imaging, then it's reasonable to think about whether or not biopsy might be indicated for that patient, because the question is, one, are they going to continue to progress and have further decline in their systolic function or have scarring? Or two, is there something else we're missing? Are we missing sarcoid? Are we missing a giant cell? Are we missing an eosinophilic myocarditis related to a medicine? All of those things have to be considered within the differential. But again, very few patients progress to that level. And by far, the majority of patients do not have ongoing inflammation on repeat MRI. Now, how about those patients who have complicated presentations? I couldn't resist putting in some treatment things for people that are interested in that. But again, once you can get them out of the hospital, you want to repeat that MRI in 3 months to ensure resolution of those myocardial changes there. Again, if they're still persistent, you want to pursue myocarditis. Now, again, depending upon how sick the patient is, if they're having VT, VF, if they're requiring inotropes or MCS, you may have a lower threshold to look for a really endomyocardial biopsy in the hospital, because again, you may be looking for things that might modify your treatment. For example, if you knew they had eosinophilic myocarditis, you would give them high-dose steroids. Their chance of recovery would be very, very high, as opposed to untreated disease. For giant cell, we know that the short-term prognosis is much different than these non- or lymphocytic or infection-related myocarditis. And so again, that may provide a different pathway or risk stratification for your patients. And so my personal threshold is much lower for those patients presenting with cardiogenic shock, VT-VF, or reduced EF. If they're not responding the way that I might expect, or they continue to get sicker, the threshold for biopsying those patients is really low. And then lastly, how about inflammatory cardiomyopathy? So again, those patients with active ongoing inflammation, you really want to look hard and think about whether or not you want to biopsy those patients. A PET scan can oftentimes be helpful to look for cardiac sarcoid or look for ongoing inflammation. And again, you may be thinking about whether or not you want to employ immunosuppression to turn off or turn down the immune system. Although there's no high quality data for that, because we know that cardiac sarcoidosis, the prevalence of that starts to increase in this population. And so again, chronic immunomodulation may be the right treatment for those patients, but if you don't have the tissue to diagnose, you may not know from that perspective. But vaccine-associated myocarditis, just one slide on that, since that has been very commonly talked about in the past couple of years. Generally very self-limited within a week of immunization, tend to have an excellent prognosis. I think there's only a handful of case reports associated with death there. Very little low risk of hospitalization. Tends to be a lymphocytic infiltration. And again, like the viral associated diseases, very age and sex prevalent. And so that tends to be in young men and young women, although men more than women. And again, probably related to how robust the immune system is. It's hard to have an immune-mediated, inflammatory response if you're in your 60s or 70s, and that kind of mirrors some of the experience from rejection, at least on the heart transplant side as well. The older you are, the less likely you are to experience rejection. Hypersensitivity myocarditis. So again, these are myocarditis that are related most often to medications. It's rare, it's uncommon. There's a few tips and tricks that you can look for those patients. About 2/3 of patients have a peripheral eosinophilia. So it's not always true that it's there, but if it is there, that can be a helpful kind of clue, especially if it's starting to rise in the setting of new medicines. Some people get fever, some people get a skin rash. And again, this is oftentimes an under-recognized disease entity. So antibiotics, HCTZ, some of the antidepressants can do it. And for those of us in heart failure transplant, dobutamine is often an under-recognized cause of some sort of myocarditis in these patients. And so for our patients that are inotrope dependent, if you notice a rise in eosinophil count for those patients, you may need to investigate that, because that can ultimately lead to clinical deterioration and quite a bit of confusion about what's going on with the patients there. And then here, just want to call out again, although the Lake Louise criteria and the MRI criteria are very good, the presence, identifying the presence of myocarditis, it does not tell you the etiology. And so again, there are cases where you want to look further, and that's where biopsy can be helpful. So what do the guidelines say about biopsy? Well, the guidelines are all expert level evidence-based, so there's not a high quality data set supporting these recommendations. What they say is that if you have new heart failure defined by less than 2 weeks with a normal or dilated ventricle, and you're hemodynamically sick, again, cardiogenic shock, it is reasonable to biopsy those patients, because you're having to consider risky or high-risk therapies in a difficult situation. If you're presenting with new heart failure and you have a high-grade LV block, again, type 2 Mobitz or third-degree heart block, if you're having VT or VF, in those patients that are not responding like you might expect to care or getting sicker, it is reasonable to biopsy those patients. And then lastly, any patient in which you have heart failure and a suspected hypersensitivity reaction and or peripheral eosinophilia, you may elect to biopsy those patients to, again, look for causes like eosinophilic myocarditis or other things that might be reversible or treated with a unique kind of subset of medicines that otherwise would not change that. So what does that practically mean? Well, if you have diagnostic uncertainty and you can't tolerate an MRI to prove you have myocarditis, that's a reasonable reason to biopsy. If you want to confirm that you have a diagnosis, for example, a checkpoint myocarditis, reasonable to biopsy. Persisting ongoing inflammation, another reason. And then again, high risk clinical situations, patient with shock, heart block, VTVF, not otherwise explained, reasonable to biopsy those patients and look for underlying sarcoid or giant cell or other entities that might merit specific situations. And then lastly, anytime you have a suspicion for kind of unusual myocarditis opportunities, again, eosinophilic or medicine related, it's very reasonable to biopsy those patients. Or when you're thinking about risky therapies such as immunosuppression or transplant, again, reasonable to look, although sometimes that may or may not change management. Just a short bit on hemochromatosis and iron overload. It comes up every now and then. We know that there's really two flavors. There's the genetically inherited hemochromatosis from the HFE mutation, and then more commonly the secondary iron overload related to transfusion-dependent syndromes, where patients receiving 50 to 100 units of blood start to increase the risk of developing iron overload and myocardial injury. No real great clinical reasons to look for it. Sometimes, of course, you get a family history. We use, obviously serum transferritin and ferritin levels to try and exclude the diagnoses. And really the backbone of this disease recognition is the cardiac MRI with, of course, T2 star. What that means for us currently is that really the contemporary diagnosis is based upon the MRI findings looking at T2 star and elevated ferritin and transferritin levels. Really no role for decisions that impact different levels of chelation therapy for those patients. What about sarcoid? So again, cardiac sarcoid really oftentimes overlaps with these chronic inflammatory myocarditis syndromes. And so again, if you're looking at a patient with ongoing chronic inflammation, particularly those with VT, VF, or heart block, we're going to pick up a fair number of these patients. You can see that those symptoms look pretty similar to those patients presenting with acute myocarditis in a complicated picture. If you look at a diagnostic approach, certainly there is a non-invasive pathway, including several major criteria here, as outlined by the Japanese criteria. But ultimately, most providers, really including myself, prefer to have some sort of tissue that confirms the disease process before you implement high-dose therapy. There are differences in whether you have cardiac or non-cardiac sarcoid involvement. And so there is a treatment kind of impact for those patients. You're trying to modify the natural history of these patients with cardiac sarcoid. And so again, confirming that they actually have cardiac involvement can lead to more aggressive immunosuppression that ultimately we hope can impact their therapy. And so again, if you need a biopsy to look to confirm the diagnosis, if you're considering highly potent immunosuppression strategies, these are reasons to biopsy. The caveat, of course, is that the yield of these biopsies is not optimal. Even if you do EKG or kind of EP guided biopsies, the yield is oftentimes in the 30 to 40% range. And so certainly once you get it, if you are lucky to get it, the role of repeat biopsy is not very helpful. We just monitor, obviously, with PET scanning here. And then very quickly, AL amyloid and TTR amyloid. So these account for greater than 95% of cardiac amyloidities. Again, I think we all now have kind of had enough exposure. We know to look for LVH with low voltages and this apical sparing pattern on echocardiogram in longitudinal strain. Those are, of course, the classic features there. Now, identifying AL, of course, is urgent. Sometimes these patients only have weeks to months to live if you identify them, and so it becomes very time sensitive. And for AL amyloidosis, I'll say this just a couple of times, there's no biopsy-free way. You have to biopsy these patients in order to prove they have the disease. And it doesn't necessarily mean you have to biopsy the heart, but ultimately, if you need to prove cardiac involvement, you have to biopsy those patients. How do we screen for AL and TTR amyloid? So again, the screening process is really centered around free light chains and a nuclear medicine PYP scan. I would highlight that a urine UPEP does not rule out AL amyloid, so I would not bank upon that. And really, the serum free light chain ratio is really helpful for our patients with AL amyloid. And you can see the representative normal, kind of gray zone, and highly abnormal. And certainly for patients that fall within these highly abnormal ranges, we are biopsying our patients within a matter of days at our center to try and get the diagnosis confirmed to start treatment for those patients. Now, if you have a negative PYP scan and a negative serum free light chain, essentially you've ruled out amyloid and so really don't have a role for biopsy in those patients. There's the patients where, again, you have a positive PYP scan and you've ruled out AL amyloid. Those patients actually don't require a biopsy. Most insurance companies now will pay for either stabilizers or silencers to treat that disease process. And so for the most time, we're able to avoid patients having to biopsy those patients in that scenario. But anytime we're suspecting AL or having other scenarios where it's a little bit unclear, sometimes in that kind of the gray zone of those serum-free light chain ratios, we really do need to move forward and biopsy those patients to look for, one, to confirm if they have the disease, and if they do have the disease, then send tissue for mass spec to confirm, again, the etiology of that amyloidosis deposition in the heart. For those that like kind of flow charts, here's just a little flow chart for AL amyloid from that perspective. Just to sum up real quick, a couple slides and have a couple minutes for questions and or cases if there's some interested for that. So again, cardiac MRI is great to diagnose myocarditis, but it doesn't actually tell you what the etiology is. For uncomplicated viral associated disease, the prognosis is very, very good. And those patients rarely need to be biopsied, but you do want to repeat their MRI imaging in a few months to make sure that the inflammation goes away. If it doesn't, then it's reasonable to bring them back for biopsy. For patients with complicated presentations or high-risk presentations with cardiogenic shock, VT, VF, or heart block, very reasonable to biopsy them or have a low threshold for biopsying those patients. Again, chronic myocarditis or concern for hypersensitivity or sarcoid, again, reasons to look to biopsy those patients. No role in hemochromatosis for biopsy, sarcoid we touched on, and then TTR increasingly is a non-biopsy diagnosis. But for AL, you're almost always going to require cardiac confirmation for those patients. And so biopsy really is the urgent kind of steadfast role to diagnose those patients in earnest there. I'll just stop real quick and see if there's any questions. If there's not, we have time for a couple of cases, but I'll see if there's any questions.
If you have any questions, feel free to please just unmute yourself or raise your hand, or you can type your question in the chat, and I will pass that along to Dr. Hendren.
Hey, Mike, it's Sam Hahn. Dr. Hunter, thank you so much. I joined a little bit late, but I got the bulk of it. Compared to our general practice, it seems like you actually do quite a lot more biopsies. And I'm an interventional cardiologist. I'm not a heart failure trained cardiologist. And I'm curious just to know what your complication rates are at your institution.
Yeah, so I would say for patients who with suspected TTR or AL amyloid, if you look at their heart and it's a thick concentric hypertrophy, I think the risk of perfing those patients is pretty low, and our experience has been very, very low in those populations. And the ones that are certainly higher risk are the ones with sarcoid, the ones with acute myocarditis, the ones that don't have kind of an infiltrative protein deposition disease. And we're very careful. So I'll use a long argon sheath. I will use a little 50-50 contrast. I'll go LAO 45, really make sure my bioptome is pointed towards the septum. And it's always nerve-wracking. I've been fortunate not to have a catastrophic or severe complication yet. So we're probably under 1% for sure, but I don't know, the exact number, but it is undoubtedly higher risk. And so we don't take that risk lightly for these patients.
And correspondingly, what is the evidence that for some of these, not the amyloid necessarily, but like the lymphocytic myocarditis and other cases where the biopsy actually changes management and actually leads to improved outcomes?
Yep, great question. So for those that have what I would call severe or kind of chronic inflammation, those that have had ongoing evidence of myocarditis for more than 3 months, we pick up about 20 to 25% of patients with cardiac sarcoid and or some other identifiable treated disease. For cardiac sarcoid, if you implement immunosuppression, there are decent data, I would say, no randomized data, that you can improve their ejection fraction, you can reduce their VT burden probably. And so for those patients, that's where we're a little bit more interested to look for them. Again, is there high quality data? There's not for sure. The acute, uncomplicated guy who's sitting in the hospital, we just leave them alone. If it's, if there's no other risk factors and people are getting better like we expect, even if they're in shock for a few days, we kind of just leave them alone. But it's the ones where they're not responding the way we want to, we're thinking about transplant, or there's several months of ongoing inflammation that's just not turning off, that we're thinking about, should we employ immunosuppression? Those are the ones that we're going after a little bit more. And that's still, of all cases, maybe 1 out of 100. So it's not terribly common, but it happens 10 to 15 times a year for us as a large referring center.
So we have a question. Sorry, go ahead. Go ahead, please.
One of the cardiology fellows. My question was about cardiac sarcoid. For example, if we have a patient with no evidence of active disease per PET FDG, but questionable findings on cardiac MRI. Question 1, if there's no RV involvement, would it be helpful to still biopsy? And number 2, what's the role in biopsy? Because it would change management if we detect sarcoid for example, for EP referral for ICD placement, if this is confirmed to be cardiac sarcoidosis.
Yep, no, it's a great question. And perhaps I'll try and answer your question with this case, just to highlight a case that I took care of earlier this year. So, a 57-year-old guy who had chronic myocarditis, 4 VT ablations, 50 ICD shocks in 18 months. Came for heart transplant consideration. I looked at this guy and I'm like, this feels like a sarcoid to me. Of course, we did a PET scan, we see his LV lights up. So we went and biopsied him and proved sarcoid there, gave him immunosuppression and turned off his VT. Now the question, if they're PET negative, I think then the yield of biopsy probably goes down substantially. And I think that's where probably the risks don't exceed the benefits, because we know that people with sarcoid can have VT even if they're not inflammatory active, because all these little areas of scar can lead to VT. And so while we hope the inflammation, if it turns off, reduces the risk of VT, we also know that if there's enough scarring that's happened, the VT risk isn't modified. And so for PET negative people with VT, we tend not to biopsy those people.
Thank you.
So a question in the chat from Dr. Pinto is, do you still do endomyocardial biopsies after transplant at UT Southwestern?
Yeah, yes, we do. Now, our protocol is in flux, I will say. For the first 6 months, I would say we biopsy on a fairly routine basis. And then now, after a year, typically we don't unless we have an abnormal cell-free DNA and some other reason for cause. Now that his practice has shifted in the past couple of years, and so will our complication rate change as we do less and less over time? We don't know. Of course, repetition, we like to think, makes us better, so we'll have to see. All right. Any other questions?
Did you have another case you wanted to share, Nick? Or
Let me see here. Yes, so last case here. So this is a 55-year-old woman who we saw probably about 9 months ago with a transfer from an outside center for us for de novo systolic heart failure, multifocal PVCs, recurrent VT, and shock. She'd had symptoms for about 4 months, but only came in a few days ago. Her initial echo had severely depressed EF, normal size RV, LV, troponin of about 1,000 for her when she came in. And we took her straight to biopsy because we were concerned that either she had sarcoid or some sort of giant cell myocarditis for her, just given the arrhythmia burden. And to our surprise, she had giant cell, which is not common. There's about 50 cases a year reported. But for her, clearly modified the treatment trajectory. We started her on very high dose steroids. We actually put her on tacrolimus. There's some debate about which immunosuppressant is best, but we have a lot of institutional experience with tacro given our use in transplants. So that was our choice for her. And ultimately, her CPET became negative as an outpatient. It was initially positive and then became negative. But similar to sarcoid, we just couldn't get the VT to stop. She had multifocal VTs, foci, probably related to the scar, related to just the disease before we got the immune system turned off and ultimately got transplanted for her. So again, these selective biopsies for patients that are at very high risk can inform treatment decisions. And for her, the other thing that was relevant was that when we did transplant her heart, we had the explant pathology that was negative for giant cell. It just showed scar. And so where that matters is that we know patients with giant cell have about a 20 to 30% reoccurrence in their transplanted heart. So she's going to be on lifelong steroids for us as opposed to a fast to off steroid regimen that would be employed for a lot of our patients. So again, these are select cases. These are maybe 1 out of 100 and 1 out of 1,000, depending upon kind of your patient population. But there is a role for biopsy here in select cases for these patients.
any last questions for Dr. Hendren from the group? All right. Well, Dr. Hendren, thanks so much for taking the time and for joining us from Dallas, Texas, and UT Southwestern. And everybody will be back next week. And thank you for joining. Have a great day, everyone.
No problem. Thank you all for your time and attention.